Can you see my screen?
Yes.
Yes. Okay. So first of all, I would like to convey my congratulations to Professor Serag and his entire team for putting up a great educational experience for everybody. And I really appreciate his efforts. Thank you very much for this kind invitation.
Thank you, Paul.
Yes,
thank you very much.
Thank you, brother. I have so many brothers in Egypt, and I feel like one of you, and I'm missing not visiting Egypt. So maybe soon we'll meet. Anyway,
Inshallah, next year would be real. Inshallah.
Yes. So, role of endoscopic ultrasound in pancreatic solid tumors. Now, the reason why we need to understand why we need EUS is that according to some of the international statistics, almost 50,000 patients every year develop pancreatic cancer and almost same number dies. And this is something which is a very, very bad disease we all know, especially the pancreatic cancer. Now, when we talk of pancreatic SOL, we are essentially talking of pancreatic adenocarcinoma, pancreatic neuroendocrine tumor, pancreatic blastoma, lymphoma, and solid pseudopapillary tumors as far as the pure neoplasm is concerned. And when we talk of SOL in pancreas, we also have to address the pseudotumors, the inflammatory head mass in a patient with acute and chronic pancreatitis, autoimmune pancreatitis, primary tuberculosis of pancreas, and some lymph node mass, which we see in our country, and I'm sure you see as well in Egypt, where a mass actually mimics as if it's a mass in the head of the pancreas, which actually is a lymph node. So these are some of the things which we need to assess before we give a definitive treatment. So what are the goals of evaluation? And I think this is something for all the students who are watching this live just now, that we need to identify, especially when you're talking of a resectable pancreatic cancer. We know that the resectable primary pancreatic cancer, the numbers are very, very small. And unnecessary surgical exploration with intended resection when tumor is actually not resectable. Now, these are the cases where we can have an impact with EUS and other imaging modalities. It also gives you an idea whether to palliate this patient and then any other neoadjuvant treatment for cancer. If you look at why we need to do this, so the 5-year survival rate of 1A pancreatic cancer is about 14%. But by the time we get into the stage 3, it is dropped to less than 5%. And as I'm sure all of us, we see pancreatic cancer very late in its expression in terms of symptoms. So we are talking of a 5-year survival rate of less than 1% or probably 1% in even expert centers. However, if you diagnose a neuroendocrine tumor, irrespective of the size, but if the stage 1 cancer has a very good operative outcomes, almost 61% will have a 5-year survival. So in an average, stage 1, stage 2 neuroendocrine tumors will have a 50% chance of a 5-year survival chances. And therefore, it is very important for us to stratify these tumors. Now, as a routine, we all know that pancreatic tumors, solid tumors, we always rely on radiological imaging, ultrasound and CT scan with contrast, and also with angiograms and MRI, and of course, then the PET CT for an overall staging. However, we feel that the pancreatic cancer in the small stage, when you start, is the carcinoma in situ, the ductal adenocarcinoma. It is so small when it starts that it hardly causes any symptoms. And by the time it reaches a size, which is about 1.5 centimeter or beyond, it starts causing some amount of symptoms. And this is the problem with pancreatic tumors we all know. So anything less than a centimeter, maybe around 12 millimeters, is going to be a challenge for conventional imaging, and that's where endosonography can have an impact. Coming to the primary staging, the TNM staging, I'm sure all of us are aware of that, so I'll skip that. And the criteria for resectability varies from center to center. In fact, there are very aggressive pancreatic resection centers where even an arterial reconstruction is done. But the question is, what is the long-term 5-year survival? And that is still a debatable issue. But we all know that any major arterial invasion will become a very difficult case to cure as far as 5-year survival is concerned. So what do you do with EUS? Now, this is my wish list, that I should see EUS like this in color. And maybe in few years from now, we will have artificial intelligence and we will have colorful EUS and not black and white. And that's what I'm waiting for. So if you look at a primary tumor, which is invading the gastroduodenal artery, similarly a supramesenteric artery and hepatic artery, or even a celiac artery, especially in cases of a body of pancreas tumor, then it becomes extremely difficult for us to resect this patient, which you will also agree will have very poor prognosis. Now, only just sonomorphological diagnosis is one aspect. The second aspect is tissue acquisition, and that's where the EUS comes in the play. So if you are looking at about 95% of patients are unresectable at the time of presentation, EUS-guided tissue acquisition will be needed in those patients for planning some kind of a neoadjuvant supportive treatment or palliative care. So when will you want a cytology? So if you have a poorly differential carcinoma, then a cytology itself is enough. If you are not going to do molecular analysis and further studies, then cytology is enough. But if it's a well-differentiated adenocarcinoma, core tissue is important. Neuroendocrine tumors, core tissue is very important. Lymphoma, same applies, core tissue, and autoimmune pancreatitis also will require a core tissue, which allows us to properly plan the treatment. There are various needles available, and I'm sure my colleague is going to talk about EUS-FNA in the following talk, so I will not touch base upon. But now we have progressed from a fine needle cytology, aspiration cytology, to pure fine needle biopsy for almost last 7-8 years in my practice. Having said that, when will you do an FNA and when you will not do an FNA? Suppose there's a patient who has a metastatic disease with a liver met. All you need is a percutaneous liver FNA, and then you don't need EUS. Or a patient with chronic pancreatitis, telltale sign of a malignancy, and you need to resect the head, then perhaps you can go without tissue diagnosis. But FNA is indicated when you have a neoadjuvant treatment involved and some other pseudo tumors which you need to rule out. So it's very important. So the importance between cytology and histopathology, as I mentioned, are specific criteria of solid pancreatic lesion where you need cytology is enough. Say, for instance, there is an advanced chronic pancreatitis and the whole pancreas is very indurated. I would not insist for a core biopsy if tissue diagnosis is indicated. I'll just do an FNA with a 25 gauge needle and I'll have the tissue diagnosis of malignancy, and cytology is enough. I'll skip this. I'll skip the rows also because my colleague will cover. But I want youngsters to understand that there are many variables which decides the overall accuracy of tissue diagnosis in pancreatic lesions. That, of course, endosonographer's experience, the kind of sedation you use where the patient is comfortable, the site of the lesion, the size of the lesion, what kind of pathology we are dealing with, the type of the needle, the technique of tissue sampling, and of course, rapid on-site cytological evaluation. Rapid on-site evaluation is extremely important when you don't have a very dependable cytopathology support. So this is something where you need to have adequate tissue before you send for examination. So I'm going to skip this, but the overall specificity and sensitivity, if you will compare the morphological diagnosis of the tumor, EUS varies somewhere around 75 to 100%, and CT has some challenges even now, especially in small lesion. So how do we circumvent some of the challenges of diagnosis in SOL? There are advances in an EUS imaging like elastography and contrast enhanced EUS, and this has added value. I won't say it would completely replace histology, but there are certain cases where you can actually avoid a biopsy or an FNA. I'll show you that case. So if you have a harmonic EUS and you want to differentiate benign from malignant, and if there is a homogeneous enhancement, we know that we are dealing with not a malignant lesion. But if there is a heterogeneous enhancement, we are most likely looking at a possibility of malignancy. So the sensitivity, specificity, and accuracies varies from center to center and expertise to expertise. But I personally reckon that I use contrast enhanced EUS in almost all cases for the last 7-8 years in my work. So anybody who is keen to do pancreatic EUS should have a contrast enhanced EUS in the department. Coming to the staging part, just for the sake of our students who are logging in today, it's important that the primary tumor diagnosis is important, but the lymph node stations such as aortic lymph nodes in the celiac artery area, or lymph nodes in the mediastinum, this will change the entire 5-year survival pattern of that patient, even if you go with a very aggressive neoadjuvant treatment and surgical resection. So this is something which we need to understand. I'm going to skip that, but these are the cases. Say for instance, this was a case in 2011 where we did not have contrast enhanced EUS, but I would have definitely not done an EUS FNA for a beautiful looking tumor in the pancreatic head genu region. This is a classical neuroendocrine tumor, which you don't need an FNA, but the surgeon insisted that I need to have a tissue diagnosis. And you can actually see the pancreatic duct is getting compressed here, leading to pancreatitis because of a tumor. So this kind of small lesions we can pick up very, very well, which is around 1 centimeter. And then you can even target them and take a proper tissue diagnosis. And this is the entire pancreatic body. And you can see I'm doing EUS FNA. Now, just for the information of our youngsters here, endosonographers, if a lesion is resectable and if your surgeon does not want an FNA, he is absolutely right. You just leave it alone and that can be resected. So if there is a resectable lesion, we also do not do FNA by and large if this patient is going for surgery. So I'm going to just skip a couple of slides, but I'm going to show you the pseudotumor part. We talked about pseudotumors, and this is something which I need to share with all of you. If any young patient with a mass in the pancreas, now this is a case of a mass in the tail of the pancreas, and this patient was advised resection of the tail of pancreas, which was actually when we did a EUS-GUIDED FNA-B, it was an autoimmune pancreatitis. Now similar, a 40-year-old young lady had a mass in the head of the pancreas with obstructive jaundice, and this was an autoimmune pancreatitis. So we always make sure that every patient, irrespective whether they are resectable on other imaging or not, we take them at least for sonomorphological evaluation of the mass so that we don't miss any distant lymph nodes or minimal ascites and sometimes some pseudotumors like this which may come up and give a surprise. So autoimmune pancreatitis you need to keep in mind, and we also do ampullary biopsy according to the Japanese studies, but in my experience ampullary biopsy is not very helpful. I think EUS-guided core biopsy is extremely important for a diagnosis of autoimmune pancreatitis. Coming to pseudopapillary epithelial neoplasm, SPEN we call it, and this usually occurs in very young patients, anywhere between 12 to 18, 20 years old, with a mass in the pancreas. When you suspect, you have to suspect something other than adenocarcinoma, and that's where you need a tissue diagnosis, because a young patient who wants to go for a major resection, if at all, then the parents are usually very apprehensive as to what we are dealing with. And this is something which we do for patients with a pseudopapillary tumor, and we take a core biopsy for them as well. Now, patient with suspected mass on a CT scan, I want all of you to pay a little attention that CT scan is not a dynamic study, unlike endosonography. And when you do a dynamic study, you can actually pinpoint where the lesion is actually arising from. So when I saw this patient, we actually saw that from the stomach, this was an exophytic GIST tumor. I will show you when I come to that point, I will show you and magnify it. And on the CT scan, it appeared like, now you can see here, this is arising from the muscle layer. This is an exophytic tumor, which was giving an impression of a pancreatic body tumor, and patient was extremely scared. So you need to have EUS in such situation. Coming to a patient who has a history of alcohol, and patient has had a large mass in the head of the pancreas, you can see here. Now these are the patients where I feel with a smooth tapering of the bile duct. Now whenever you see a smooth taper of the bile duct, we are essentially looking at an inflammatory head mass rather than a neoplasm. So this is something which all endosonographers should keep in mind, that on EUS, if you see a taper of the bile duct lower in the intrapancreatic portion, we are looking, and you can see how This is homogeneously enhancing lesion. This is an inflammatory process in a setting of alcoholic chronic pancreatitis. Now, there are patients who have seropositive status, lymph nodes, and a mass in the head of the pancreas. And I had this kind of a patient long time ago, almost more than a decade ago, where patient had a huge diffuse mass with minimal ascites, and the core biopsy at that time was not possible, but we still try with a true cut needle, which was introduced by at that time, and we found that there was a lymphoma of pancreas. And this whole thing changed, and even we took a biopsy from the lymph node, and then of course patient had jaundice, so we need to treat that as well. Coming to young patients who had mass in the head of the pancreas, and again advised Whipple operation. So whenever you talk of mass in a young patient, you have to ask questions. Are we dealing with something else other than adenocarcinoma? And in this case, this patient had a primary tuberculosis of pancreas, which we proved on EUS-GUIDED FNA. I usually do a biopsy just below the stricture of the bile duct. Now, this is the CBD stricture, so I usually go very close to the stricture of the CBD, and that's where you get the proper diagnosis. And why only ERCP would have been done? Because we did ERCP for draining of the biliary system because patient had jaundice. So brushing was negative for diagnosis. So only ERCP would not have worked in this case. Now coming to chronic pancreatitis, as we do a lot of chronic pancreatitis endotherapy, whenever a patient has a chronic pancreatitis with jaundice, all of you should have a heightened awareness of a possibility of a tumor in the setting of chronic pancreatitis. And this is exactly what we found in this young man of 28, where we found an irregular tumor in the head of the pancreas, a dilated pancreatic duct you can see on EUS. And this is the hypoechoic lesion causing abrupt narrowing of the bile duct you can see here. And this turned out to be an adenocarcinoma in a setting of chronic pancreatitis. When you talk of inflammatory head mass, now this is what I'm talking of, inflammatory head mass. Very large, bulky head, heterogeneous appearance. You can use contrast enhanced EUS, and then you can have a diagnosis. When you talk of very small lesion, now I know this patient, 35-year-old young lady, all of you need to pay attention in this case. She was referred to me for endotherapy of chronic pancreatitis because she had a dilated MPD in the body and the tail area. Now I want all of you to pay attention what I found. While we were doing endoscopic ultrasound, we picked up a hypoechoic lesion in the body of the pancreas, which was less than a centimeter, 8.5 by 7 millimeter. This was a ductal adenocarcinoma, sub-centimeter ductal adenocarcinoma. I told them this is a tumor, you need to get operated, but since she was 35 and not prepared for a surgical resection, the surgeon insisted on FNA, and I used an EUS-guided FNA with a 25 gauge needle. A 25 gauge needle got me a diagnosis of ductal adenocarcinoma in a less than a centimeter lesion in the body of pancreas. So this is the magic of endosonography if you use it in its right context. Coming to the contrast enhanced EUS, which I mentioned, I had this patient referred, 80-year-old lady who was having a suspicion of some kind of a neuroendocrine pathology. Her stomach on high resolution endoscopy was showing very, very funny images. So that was not very important. We took some biopsy, we did chromoendoscopy, and she had neuroendocrine pathology of the stomach as well as a pancreas. So when I did endoscopic ultrasound for this patient, you will see hypoechoic diffuse thickening up to the submucosal layer you can see here. And when we did contrast enhanced EUS, we picked up an incidental pancreatic neuroendocrine tumor on EUS. So I want all of you to pay attention here in the very interesting case where we did EUS. On a regular EUS, I saw a tumor in the head region here. And then we did contrast enhanced EUS. So when we did contrast enhanced EUS, you see what happens to that lesion. It's again 1 centimeter lesion, as you can see. Immediately we did contrast enhanced, and it lit up like a bulb when the contrast was injected. And this gave a confirmation of the diagnosis. See how beautiful it is lighting up. You don't even need to put a needle in this case, and you can be very sure that we are dealing with a neuroendocrine pathology. Coming from just sonomorphological diagnosis to therapy, there have been attempts to do EUS-guided RFA, an alcohol injection for palliative care, but it is still experimental in my view. So guys, if you have a pancreatic solid lesion and fit for patient for therapy, of course, start with a CT scan. If it is unresectable metastatic disease, perhaps in liver, you can have a percutaneous biopsy. If it's a locally advanced or borderline resectability and you're planning to give a neoadjuvant treatment, you go for EUS-guided tissue acquisition. If it's a resectable lesion, suspicion of diagnosis other than adenocarcinoma, then definitely you will need a definitive tissue diagnosis. If other investigations prove that it's a definite tumor and resectable, then you don't need EUS-guided intervention in such situation. And if it's a very advanced tumor and you still want to resect and you want to have anterior chemotherapy, then you need an EUS-FNA. So if you ask me my observation and recommendation, I think the overall sensitivity specificity of EUS in the staging of pancreatic cancer is comparable to other imaging, but it scores over other imaging in small lymph nodes, minimal ascites, and distant lymph nodes and small liver mets. EUS is extremely helpful in pseudotumors of pancreas. It's a very subjective technique, so experience matters. It gives a very detailed examination of pancreas, and the negative predictive value of pancreatic SOL on EUS is so high in experienced hands that if I see a normal pancreas, very unlikely any imaging will show a tumor, and it should be ideal way of tissue acquisition would be EUS-FNA, not CT guided if you need. And of course, you have to understand that the addition of elastography and contrast enhanced EUS will allow you to direct your biopsy properly and also sometimes stratify a tumor like neuroendocrine, which does not need an EUS-FNA. So in my view, EUS is an indispensable modality for solid pancreatic tumors. Those who are not doing should start learning and doing. Thank you very much.
Thank you, Professor SOUD, for this elegant lecture with clear messages. And actually, we will postpone the questions at the end of the sessions, and we are waiting for your last lecture at the end of the session. And
Yes.
greeting to Krishna.
Yes.
Thank you.
Thank you.
Now we shift to Saudi Arabia, where we have Professor Dr. Saad Zahrani, consultant gastroenterology and advanced in therapeutic endoscopy, endoscopist, head of endoscopy unit in King Abdullah Medical City from Mecca. You are welcome, Professor Saad, and he is going to give us a talk about role of EUS characterization of cystic pancreatic lesions. I think it is a hot topic, and still there is controversy in this subject. We are waiting for you, Professor Saad. You are welcome.
Assalamu alaikum. First of all, I would like to thank you for inviting me in such important scientific meeting, and it's my pleasure to be here. Today, I'm going to talk about endoscopic ultrasound characterization of the pancreatic cystic neoplasm. I'm going to give a brief introduction, then talking about EUS characterization of pancreatic cystic neoplasm, what is new, then take-home message. Technological advances and increased use of medical imaging have led to an increase in the identification of pancreatic cysts in patients who undergo cross-sectional imaging. Studies show that prevalence of pancreatic cyst is about 2 to 20% of all patients who undergo MRI and about 2% who undergo CT. In autopsy series, pancreatic cysts were found in about 25 to 50% of autopsy cases. The prevalence increased with age, and up to 10 to 40% over 80 years old have pancreatic cyst. So pancreatic cystic lesion can be classified into 3 categories: benign cyst, like simple cyst, pseudocyst, retention cyst, and hydatid cyst. And second category is cyst with malignant potential, like we call it pancreatic cystic neoplasm, and there are 4. And third category is malignant cyst, like pancreatic adenocarcinoma with cystic degeneration and cystic pancreatic neuroendocrine tumor. Now, the second category is the most common cause of asymptomatic pancreatic cyst, and it's the most challenging part to diagnose and to manage. This is the WHO classification of neoplastic pancreatic cyst. There are 4 types: 2 mucinous cysts, which are mucinous cystic neoplasm and IPMN, and the other cysts are not non-mucinous, like cystic, serocystic neoplasm and solid pseudopapillary tumor. So in order to approach pancreatic cystic neoplasm, you're going to have to answer 4 questions. First question is to determine the type of the cyst. If they are serous, like serocystic neoplasm, then reassure the patient. If they are solid pseudopapillary tumor, then management is straightforward, surgical resection. If they are mucinous cysts, then the second step is to determine if they are malignant or not. And if not, then you're going to have to determine what is the risk of malignant transformation. After answering this question, you'll be able to decide about the management plan. Now, in order to answer all these 4 questions, you have to utilize every single information you could from history, from images, from endoscopic ultrasound, and fluid analysis in order to answer them. Now, there is no single test accurate enough to diagnose to assure a definitive diagnosis for all pancreatic cystic lesion. So you have to utilize every single information you could. And having said that, endoscopic ultrasound considered the most useful test and have the best performance in comparison to other tests. Advantages of endoscopic ultrasound: it can accurately visualize the cyst morphology, assess the vascular pattern by contrast harmonic scan, and also perform FNA and evaluate the cyst fluid. EUS FNA has sensitivity of 91, specificity of 75, and accuracy of 85% for diagnostic pancreatic cystic neoplasm. Now, you don't have to do endoscopic ultrasound for every pancreatic cyst, and this is the indication to do endoscopic ultrasound evaluation for pancreatic cyst. If there is any worrisome features in form of cyst more than 3 centimeters in size, or cyst that increasing in size rapidly more than 5 millimeters over 2 years, or patient with dilated pancreatic ducts more than 5 millimeters, or if there is high risk features, or if there is mural nodule, or thick wall, or there is high serums in antenna level or lymph node. Or if you're uncertain in diagnosis, especially if the cyst is more than 1.5 centimeter or 2 centimeters in size, so you can take a fluid sample. The drawback of EUS exam is that the procedure is operator dependent and relatively invasive. Now we'll go to our main part, which is endoscopic ultrasound characterization of pancreatic cystic neoplasm. Of course, first thing you want to know is the morphology of the cyst. As you know, there is some pancreatic cystic lesion have very typical morphology, and then diagnosis would be easy. You want to know the shape of the whole cyst, the state of the cyst wall, and the internal state of the cyst in terms of septation, mural nodule. You want to know the number and size of the cyst. You want to know the location of the cyst, and if there is communication with the main pancreatic duct. You want to evaluate for pancreatic duct dilatation, and also evaluate for any background lesion or changes of pancreatitis. So this is how you see mucinous cystic neoplasm in endoscopic ultrasound. You see large unilocular cyst that has thick wall. You might see it as unilocular. You might see it like or multiloculated cyst with septation. If you're lucky enough, you might see peripheral calcification, which is almost pathognomonic in mucinous cystic neoplasm. But you will see this in less than 15% of cases. And this is how you see serous cystic neoplasm in endoscopic ultrasound. And this is a very classical, typical serous cystic neoplasm. You see macrocystic, you see how you see this very tiny macrocyst. We call this macrocystic honeycomb appearance. And this is very typical of serous cystic neoplasm. However, you might see serous cystic neoplasm can present as you can see here, macrocystic oligocystic lesion, and confuse you with mucinous cystic neoplasm. If you see central scar, if you're lucky enough to see central scar, then this is pathognomonic for serous cystic neoplasm, but you'll see this only in less than 15% of cases. And this is how you see solid pseudopapillary tumor in endoscopic ultrasound. You will see well demarcated mass. You might see some cystic degeneration changes here. However, it might present as purely cystic lesion. You want to know the location of the cyst, especially with mucinous cystic neoplasm, because this is a disease of the distal pancreas. So mucinous cystic neoplasm, disease of female. It's happened in female in more than 97% of time, and a disease of distal pancreas. So it affects the body and tail of pancreas in more than 97% of time. Multiplicity and communication with the main pancreatic duct is very important feature. So if you see multiple cysts communicating with the main pancreatic duct, this is branch duct IPMN, and there is no other differential diagnosis except cystic changes secondary to pancreatitis. Size of cyst. For small cysts, endoscopic ultrasound is more accurate. For larger cysts, CT and MRI is more accurate to determine the size of the cyst. Now, most of the guidelines address the size of more than 3 centimeters as a worrisome feature, and therefore as it's an indication for endoscopic ultrasound evaluation and FNA. However, size itself is not an indication for surgery. Even if the size is more than 3 centimeters, you're going to have to look for another risk factors. If there's no risk factors, only the size, so the risk of malignancy is there, but it's very low, and this did not dictate referral for surgical resection. Actually, the cyst growth during follow-up is more important than the cyst size at first presentation. One of the very important features is to evaluate the pancreatic duct. Pancreatic duct dilatation more than 6 millimeters is a worrisome feature, and pancreatic duct dilatation more than 10 millimeters as an indication for surgery. Mural nodule or solid component. This is one of the strongest predictor of malignancy and should be considered an absolute indication for surgery. Contrast enhanced endoscopic ultrasound appear to be the most accurate tool for differentiating mural nodule from mucin ball. With very low rate of false negative, it has 96% specificity, 75% sensitivity, and 84% accuracy. Now, most guidelines endorse that presence of enhancing mural nodule of more than 5 millimeters in size represent a clear indication for surgery, and risk of malignancy appear to be directly proportional to the size of the mural nodule. Sometimes it's very difficult to differentiate in endoscopic ultrasound exam between the mural nodule and mucus ball, and here is some tricks to differentiate between them. The mural nodule usually attached to the wall of the pancreatic duct or cyst wall, while the mucus ball is mobile, moves with patient repositioning or probing with the needle. The mural nodule is iso or hypoechoic structure without smooth edges, while with the mucus ball you will see the halo sign, which is smooth edge with hyperechoic rim around the hypoechoic center. Now the mural nodule, you will see it's going to be a positive Doppler, and it can be a positive Doppler, and as we mentioned, endoscopic contrast enhanced endoscopic ultrasound can allow demonstration of the blood flow inside the mural nodule, and it's the most sensitive test. Histopathology is positive with mural nodule. And here how you see it in endoscopic ultrasound. The picture here in the left of the screen showed mucus ball. You can see halo sign like hyperechoic margin with hypoechoic center, and is not very attached to the wall. While here the mural nodule, you can see it's very attached to the wall and has irregular border. I'm going to share with you a few cases that I have done this month for evaluation of pancreatic cyst. I'm sorry for the quality of the video. So this is a young female patient. Her age is 34 years old, and I'm found to have incidentally to have multiple pancreatic cysts. She has a cyst in the neck of the pancreas, as you can see here, a small cyst measuring 1.1 centimeter and communicating with the normal main pancreatic duct. This cyst has no worrisome features in terms of mural nodule or thick wall, and you see like the pancreatic tissue is normal around. and trying to examine the rest of the pancreas, you see here the normal pancreatic tissue. There is no changes of pancreatitis. And you can see here, moving to the tail of the pancreas, sorry for the bad quality of the video. And you see here another cystic lesion. It's macrocystic septated lesion. It has large and small cysts at the same time. Has no high-risk features in terms of mural nodule or thick wall. So if you see multiple cysts communicating with the main pancreatic duct, so this is branch duct IPMN, has no high-risk feature except the size. You don't need to refer the patient for surgery at this time and just follow up with images. Another old patient in her 70s, incidentally found to have pancreatic cyst. And you see here normal pancreatic tissue, and you see here a septated cyst that measure 2 centimeters in size. This cyst has no mural nodule or thick wall, and it has very clear communication with the main pancreatic duct. As you see here, main pancreatic duct is normal, is not dilated. And this is another case of branch duct IPMN that doesn't have any high-risk features or any worrisome features, and the management is just follow up with images. So now we'll proceed with cystic fluid analysis. Cyst FNA is relatively invasive and should be done only when you think it will change the management plan. So when you aspirate fluid, you should comment on the physical appearance of the fluid. If it's bloody and non-viscous, then this is suggestive of serous cystic neoplasm or solid pseudopapillary tumor. If they are viscous, small amount, then this is suggestive of IPMN. If they are large amount, then this is suggestive of mucinous cystic neoplasm. And then you should do, and then better to do a string sign if you have enough fluid by dropping, by putting a drop of fluid between your 2 fingers and try to separate them apart, trying to stretch the drop. If it's from a string of more than 1 centimeter in size for more than 1 second, this is positive string sign, and this is very high specific for mucinous cyst. CA-level is one of the most useful tests in cyst fluid. It's used to distinguish between non-mucinous and mucinous cyst, but not to distinguish between malignant from benign cyst. There's multiple cutoff value in the literature. The best balance between specificity and sensitivity is 190 value, a cutoff of 192. It has 80% accuracy for diagnosis of mucinous cyst. Keeping in mind, low CE level does not exclude mucinous cyst. Low CE level of less than 5 has 50% sensitivity and 95% specificity for serous cyst. Amylase and lipase level reflects duct communication as in IPMN and pseudocyst. We use amylase and lipase level to rule out pseudocysts when they are very low, less than 25. They exclude pseudocysts with very high specificity of 98%. Cytology of the evaluation of cytological specimen in pancreatic cyst is hampered by low cellularity. Studies showed that only 34% of cytology sample had adequate cellular material. Also, cytology suffers from low sensitivity, but it has good specificity. So the strength of cytology in its specificity. So once you get suspicious cytology, you should refer a patient to surgical resection. So if you do all these tests, you will diagnose most of the pancreatic cystic neoplasm. However, as we mentioned, all these tests is suboptimal, and you will left with few cysts. You call it as indeterminate cyst, and you want to do something else. So here is few tests or technology that you could use for now, but still we need more study to tell us when to use it and how to utilize it. Molecular analysis. These tests suffer from low sensitivity, but they have good specificity. KRAS mutation has sensitivity of 45 to 65% and specificity reaching to 100% for detecting mucinous pancreatic lesion. Positive GNAS mutation can be used to differentiate between APMN and mucinous cystic neoplasm. A mutation in tumor suppressor gene TP53 has been associated with high-grade dysplasia or invasive carcinoma. Mutation in von Nibelendo have been associated with the serous cystic neoplasm. These tests are expensive and not available in most of the center, and further studies are required to validate this result and to determine the clinical utility of many of these markers. Cyst fluid glucose level. Cyst glucose level has emerged as a useful cyst fluid marker for distinguishing between mucinous and non-mucinous cyst with accuracy similar or even better than CEA level. There is multiple small studies showing promising results with cyst fluid glucose to differentiate between mucinous and non-mucinous cyst. However, we still need a larger prospective study to validate this result. And for now, you cannot use a cyst fluid glucose independently to differentiate between mucinous and non-mucinous, but you can use it as a complementary test to CA level. EUS-GUIDED through the needle biopsy. So this is MURAL biopsy. And this is how to use it. You have to stick the cyst with 19 gauge FNA, and then you pass the needle through you pass the biopsy forceps through the 19 gauge FNA needle, and it's very visible, very clear under in the EUS screen. And then all what you have to do is just to take biopsies from the wall or from the mural nodule if there is. So recent systemic review and meta-analysis published in 2020 aimed to assess the feasibility and safety and diagnostic yield of this technique.
Time.
Okay, sure. And they found this technique is very feasible with success rate 98%, safe with the relative complication is about 70%, most of them, sorry, about 7%, most of them hemorrhage and pancreatitis, and they were mild self-limited. And the diagnostic yield and accuracy of this technique was reaching to more than 90%. EUS-GUIDED FNA needle-based confocal laser endomicroscopy. It's also a novel technique. You need to stick the cyst with 19 gauge FNA needle, and then you pass a laser probe through it, and you place it against, and you move it gently against the wall to get a real-time microscopic evaluation of the cyst wall and vasculature, and you get this microscopic feature. You can see here like a capillary projection indicating APMN, or you see superficial vascular marking this whitish area suggestive of serous cystic neoplasm. So systemic review revealed that.
Sorry, but the time is over.
Okay, so I move to take home message. Pancreatic cystic lesions are common and accurate diagnosis can be challenging. There is no single test accurate enough to assure definitive diagnosis for all pancreatic cystic neoplasm. You have to utilize all the information that you could to get a definite diagnosis. EUS through the needle biopsy and EUS confocal laser endomicroscopy are promising techniques that will improve the diagnostic accuracy of the pancreatic cystic neoplasm in the future. And thank you.
Thanks for Chairperson. We'll now move to our presentation about EUS-FNA, how I do it. This is our agenda. We will talk about needle parts, needle design, how to select the needle, how to master the technique and handling of the sample. The first part is EUS-FNA started in 1991 for diagnosis for the first case for mucinous cystic lesion. Since that time, rule of EUS-guided tissue acquisition increased significantly. EUS-FNA is a multi-step procedure. It includes proper clinical indication, correct selection of FNA needle type, and adoption of evidence-based techniques. So we will move to each part. First part is the needle parts. We all know needle is formed from needle itself, the covering sheath, and the handle of the sheath, handle of the needle itself, and the stopper, and finally the suction syringe. Needle design is very important for anyone who is going to do EUS-FNA. You should know all type of needle and how to choose the proper needle. We have FNA and FNB needles. FNA are available in many sizes, which is 19, 22, and 25 needle, which have regular tip needle. Then we have FNB needle in 3 generations. The first generation, which was not popular, which was a quick core needle. It was through cap biopsy. It was 19G needle, but it was unpopular because it was a stiff needle. Then Koch presented the second generation, which is a pro-core needle available in all sizes, but it have a reversed bevel. After that, the third generation, which is a popular now, we have the charcoal needle. We have the acquired needle available in 22 and 25. We have the pro-core needle, but with forward bevel, which is available in one size only, which is a 20G needle, and it's also a flexible needle. And we have the German needle, but not available in Egypt, which is called top gain needle. How to select the needle? Selection of the needle is very important. Each needle have advantage and disadvantage. We don't have a classic needle to select in all cases. So large caliber needle like 19 and 20G have more tissue material, but they have more bloody sample and are less flexible to manipulate. Unlike the small needles like 22 and 25, we have less tissue material, but non-bloody sample and more flexible needles. So to select, we have many important items. The first item is the site of the lesion. For the site of the lesion, esophagus, gastric, and rectum, you can choose any type because manipulation is easy. But for the duodenal bulb, if you are going to do therapeutic maneuver, you can go for 19G needle. If you are going to do FNA or FNB, you go for the 22 or 25. For the second part of the duodenum, you can only use the 22 or 25, especially for the answering process. It's preferred to use more flexible needle like the 25 one. The second part to choose a needle is the characteristics of the lesion itself. You look at many parts, not only the site of the lesion, you look for the criteria of the lesion. If you have like lesion with cystic degeneration, which make the tissue is more soft and easy to aspirate. Also, you can see the consistency of the lesion using elastography to determine if the lesion is hard and fibrotic. You will need FNB or a larger size needle. Also, if you need immunohistochemistry, you should go for FNB or obtain core tissue diagnosis. So, what the literature say about selection of the needle? Most studies, including meta-analysis, show no difference between 22 and 25G needle, except for the pancreas. Some studies, especially for answering process, says that 25G needle is superior to the 22 because you can manipulate the lesion easily and needle easily in the answering process. You are going in the second part of the duodenum, difficult manipulation for the needle, so better to choose 25 needle. For the 19G needle, although theoretically larger size, but no added benefit. The second question is you go for FNA or go for FNB needle. Also, recent meta-analysis comparing 22G Procure with the standard 22G needle show no difference. Procure, which is the second generation, have the same diagnostic accuracy like the 22 regular needle. But you only have fewer passes, which is the only advantage. But for the third generation, comparison of the fork tip, charcoal needle, and the acquired needle shows that both have superiority for the diagnostic accuracy compared to the regular 22 needle. So to choose between charcoal or acquire, also meta-analysis showed no difference between fork tip or charcoal needle with the acquired needle. Finally, a recent study measuring the length of the tissue between the 22G acquired needle and the 20G pro-core needle showed that the acquired needle is superior. You have larger core up to 8 millimeter for the core, or maybe longer in some cases. So for the selection, this algorithm may be conclusive. It's tailored approach, as we mentioned, no standard needle. You go for tailored approach, depending on many factors: patient factor, institute factor, and lesion factor. For the patient factor, if you have patient with chronic pancreatitis, you should go for FMB needle. For the institute factor, if you have a rose, you can go for FNA is enough because you can have rose. And if you are diagnosing pancreatic suspected adenocarcinoma, you can go enough for FNA. Lesion factor, which is the most important, you can go for FMB needle if you have a small lesion or need immune stain like neuroendocrine tumor, like lymphoma. You should go for FMB because you need longer core or tissue diagnosis to confirm. But if you have suspected adenocarcinoma, no added benefit, FNA like FMB. But you go for FMB only if you are going to do genotyping. Also, for difficult lesion, prefer not to repeat diagnosis and go directly for FMB, but you can use also FNE needle. This is called tailored approach. No standard needle or no accurate needle. You go for according to many factors. Third point is how to master the technique. We have many tips to get good FNA. The first step is no elevator aid. When you achieve a position, you can go with the needle without movement of the elevator, just by going with a big wheel up and down. It makes it easy to do fanning and easy to acquire the biopsy. The second tip is lesion proximity. Before you go for FNA, you get the lesion to the closest part to the probe, so you can manipulate easily the needle itself. The third point is the puncture track. When you are going to do transgastric biopsy, it's much more difficult than transduodenal biopsy because you need a greater force to pass the stomach itself, which makes the manipulation a little bit difficult than the duodenum. So if you have a pancreatic head lesion and you can take it from stomach and duodenum, you should go for the duodenum because it's easy to manipulate. And the last part is the puncture target. When you target lesion, where to go to the lesion, center or the periphery? No, you should go not to the center as much and not to the periphery too much, because you have desmoplasia and peritumoral inflammation in the periphery and you have necrosis in the center. Also, we can be aided by the elastography. Elastography, it shows the stiffness of the target lesion. You should go for the blue part, which is the most hard part of the lesion, to acquire better results on cytopathological examination. So we have many techniques to take the biopsy. First one is to choose between fanning technique and multipass technique. Fanning is like this image. You can move like a fan inside the lesion to acquire tissue from most of the lesion. Or multipass, you can go out after the pass and enter the lesion again. To and fro and knock the door. To and fro, it means movement in and out inside the lesion, or knocking the door, it means pushing and letting the lesion to go back. You should go for 5 to 20 to and fro movement per pass, and you should take at least 2 passes from the lesion. You can depend on something what's called MOS, which means macroscopic examination. If you have core, like this core, more than 4 millimeter, it's adequate core. You see no blood staining inside the tissue itself. This example of the techniques, the first technique is fanning technique. You first check by photograph, the lesion is then the medium is punctured inside the lesion. So fanning it means after 2 and 3, I move in different direction. Like this, to puncture most of the needle without coming out from the needle. This is called fanning technique. And this is the most accepted in different guidelines. You should move, suction, but you should do fanning. It means moving to different parts of the lesion like this. The second technique, which is called the multipass technique. Multipass means also 2 and 3 movement inside the lesion, but coming out from the lesion. Also, check by Doppler, in close proximity. Then we enter the lesion within 2 and 3 movement, like this. Then we come out with the needle and do another puncture in another direction. Like this, we can come out of the lesion without passing the wall. Just only outside the lesion and enter the lesion again to make the movement in different direction. Which is called the multipass technique. The third technique is knock the door. Knock the door is used before heart of hydrotic lesion. Heart of hydrotic lesion is difficult to do failing inside the lesion or do multipass. So also we can use it as a stomach because the lesion is relatively mobile. So it's just like knocking the door. You push and the lesion goes. You push again. It's called knock the door technique. To the second question, to use stylet or without stylet, the theoretical advantage of the stylet is it prevents blockage of the needle from the duodenal wall or the gastric wall before entering the needle. However, most of studies show no difference between using stylet or no using for stylet. So it's not a big issue to use with or without stylet. The third question is to use slow pull technique or suction technique. Slow pull, it means during movement inside the lesion, the stylet is withdrawn slowly to create a slow negative suction inside the needle. Suction technique, it means using syringe for adopting negative suction during movement inside the lesion. Both have comparable diagnostic accuracy between slow pull technique and suction technique. Our own experience, we prefer to start by slow pull technique as first. If we don't have adequate tissue or we have hard lesion, we can repeat second pass using suction technique. Some studies or single randomized control study showed that wet suction may improve the diagnostic accuracy. However, most of studies show no advantage for using wet technique for FNE. Last point is handling the sample. We have two preparation. We have the cell block and we have the smear fixation. If you are wishing to do immune stain, you go for cell block mainly. Most of tissue should be cell block for immune stain. If it's adenocarcinoma suspected before doing FNE, you may only depend on smear fixation. On different slide, you can prepare the needle smear like this and fix in alcohol more than 70%. So to take a home message, success of obtaining a representative sample depend on many factors, not only one point. And the ideal needle and the puncture technique should be individualized according to each patient. And thank you.
Thanks, Dr. Ahmed, for this wonderful lecture. We'll back again to the India, Professor Rathod. We talk about current situation of interventional EUS.
Thank you very much. I enjoyed both the presentation, Dr. Saad, and this amazing presentation on FNA. Well done. Congratulations. Coming to interventional endoscopic ultrasound, my respect to all the chairpersons today. Thank you very much for giving this opportunity. As our previous speaker mentioned, the doorway or the gateway to interventional EUS is the history of interventional EUS, where actually the first prototype came in 1988. And my friend, Dr. Peter Willman, was probably one of the first guys to do this. And we thank such pioneering masters to have given this doorway for EUS-guided interventions thereafter. So if you look at the types of interventions we do for various problems, on the top of the list would be pancreatic fluid collections, celiac plexus neurolysis, biliary and pancreatic ductal drainage, ablative techniques for tumors, vascular interventions, and anastomotic applications. So what are the requirements, like the technical requirements for anybody who wants to start therapeutic endosonography? You definitely need a linear scope and high resolution fluoroscopy. You don't always need a fluoroscopy, but it's a good adjunct when you start your career. The most important part of an interventional procedure or therapeutic endoscopic procedure is a well-trained endoscopy assistant. So that is going to be a very important, because EUS or any therapeutic ERCP procedure, the margin of error is very low. And therefore your assistant has to be extremely experienced and well-trained to help you to minimize the time of intervention, so that will take care of the complications. Of course, you need needles, you need guide wires, you need cystotomes, needle knife, balloons, and of course stents, plastic, nasobiliary drainages, and lumen opposing metal stents. And on top of everything is a very, very experienced endoscopist. So EUS, linear therapeutic EUS, sounds like a very, very fancy and a very attractive it adds a lot of glamour for your work. But let me tell you, the indications are very limited as of now, which are established, which we'll talk about. So you need a very good training. So training cannot be replaced with any other short courses or visits. I think a proper training is important. Coming to pancreatic fluid collection, I was extremely fortunate that we started way back in 1999. So I was very lucky to start EUS guided intervention way back in 1999. And those were the days when there were no metal stents or just plastic stents were available. And we were doing a combination of, and those scopes were in those days not even therapeutic scope. So I would put a needle, put a wire, and then exchange it for a naso or ERCP scope, and we complete the procedures for duodenoscope exchange. So this is how the journey of interventional EUS started as far as the pancreatic fluid collection is concerned. And then, of course, as we evolved, we become more and more aggressive in our approach. So we started with transgastric and then came transesophageal. Even in transesophageal, as you can see here, that you can't leave a metal stent in the esophagus. So this is still holds true even today, despite all the advances in lamps. That if you, and I did it in 2005, as you can, or 6, you can see here, that transesophageal drainage also is feasible, and you can possibly drain a fluid collection from there. Coming from there to acute severe pancreatitis with a fluid collection which is less than 2 weeks old. Now, this is a highly debatable area. I'm sure all of you would agree that we always give a timeline of, say, XYZ amount of time. You need to wait for 4 weeks or 6 weeks before the wall matures. But I'll tell you the trick here. This is almost a decade ago we did this case, and it's a huge fluid collection. Look at the kind of wire which is there inside the cavity, and patient was just not thriving or not tolerating anything. So the best technique to do this is do not dilate it. So when you have a very thin wall of the fluid collection, you don't do any balloon dilatation, minimum dilatation, do your stent placement, leave a nasocystic catheter for a control of the aspiration of the fluid out, and that takes care of this patient even within 2 weeks of acute severe necrotizing pancreatitis with a large fluid collection. Look at the size of the stent I have placed inside. So this is something which has changed our perception. And of course, with the help of color Doppler, any kind of vascular structures in between, you can manage with color Doppler guided interventions, and we can drain the fluid collection. But what really changed in pancreatic fluid collection is the development of metal stents, especially covered stents and the lamps. So I still remember I did probably the first EUS guided necrosectomy in 2001, almost 2 decades ago. And those were the days where there was no metal stent and very few accessories dedicated for these procedures. And I was inspired by my professor Nip Sohendra and Ken Bidmola as I was in Germany for a year and a half. So we took this challenge and we started doing that. And now we have established techniques of even treating pancreatic necrosis with a self-expandable metal stent. And then you do endoscopic necrosectomy through the stent. And then you can have a very established way of treating these patients. So if you ask me, if you choose a right case for endoscopic necrosectomy along with percutaneous approach, this is still probably one of the best approaches for a better outcome in these sick patients. Coming to more advancements, I'm indeed grateful to my mentor, Ken Bidmola, who is a developer of this hot axios, as we all know. And I feel that this particular platform is probably the only dedicated platform for EUS guided intervention currently. So with this hot axios, you can just deliver under one puncture. In 5 minutes, you are draining the fluid collection. So essentially in my practice, we do not do plastic stenting of fluid collection, even if it's very clean fluid. We always put a Nagi stent or a hot axios if patient is affording, but always a metal stent so that we do not have any issues of undrained segments of the cavity which gets infected later on. So this is something which you need to understand. And there have been studies which have shown the efficacy and the safety of LAMS in world of pancreatic necrosis. A lot of studies have also showed the overall pooled analysis data that we are slowly inching towards a least invasive option of pancreatic fluid collection, or WOPN, rather than a surgical intervention. So it leaves a very little doubt in my mind, at least, that if you have a patient with infected necrosis with a single large cavity, then you can have a very good outcome with a combined approach, both endoscopy as well as percutaneous tract route. I don't want to go into the very fine details of the things, but there has been a series of studies which has shown complications high, but as we grew in the experience, the complication rates have started coming down. And I think more and more people are getting trained in this particular area. So how do we use this LAMS, the lumen opposing metal stents, and where it can be used? So we can use in pancreatic fluid collection, you can use in biliary obstructed systems, you can drain the gallbladder with the same thing, you can create a gastrojejunectomy, enterostomy, and all this kind of procedures can be done with this one platform. So if you ask me today, if there is one platform which is dedicated for EUS, that is this particular platform. Coming to EUS-guided biliary drainage, I was extremely fortunate way back in 2001, almost 2 decades back. I think Mark did it in 2000, sometime end of 2000, and we did it in 2001, the first EUS-guided biliary drainage. And that indication was purely that there was no duodenal access because of a tumor, patient had a gastrojejunectomy, or failed ERCP, altered anatomy, contraindication for PTC, and of course, now with more and more bariatric surgical options are given to patients, I think we are going to need this kind of interventions for sure. So this is, as I said, my first EUS-guided biliary drainage almost 2 decades back with a plastic stent, and that too was a 7 French stent, and it got blocked in some time, so we never published this. But this patient ultimately had to be done a percutaneous tract or plastic stenting in those days. So what are your biliary drainage options? We have biliary drainage options in the form of choledochoduodenostomy, a rendezvous technique, either duodenal, gastric, or antegrade. And you have hepaticogastrostomy, choledochogastrostomy, and direct gallbladder drainage. So if you ask me my particular preference of drainage, I would prefer to do a transduodenal EUS-guided choledochoduodenostomy as a safest possible procedure if there is a massive dilatation of the bile duct, which is impinging on the duodenal bulb region. And this is something which I personally reckon. Now it could be, it can have a conflict with already published data, but as you can see, I am sitting in the duodenal bulb and a massively dilated system, that's a hepatic artery, and you can puncture under EUS guidance, place a guide wire in the right system, and then of course, leave a specially designed 4 centimeter covered stent to create a choledochoduodenostomy. So according to me, this is probably a very, very straightforward. It takes about 10 minutes if you have a very good assistant to perform this procedure. Coming to the hepaticogastrostomy part. So if you have complete obstruction of duodenum or surgical anatomy has been resected or anything, then you have no option but to go through the liver. And I personally would choose only to do this procedure if I'm pushed in the corner where there is no other option but to drain this way internally the biliary system. So I would still prefer an antegrade drainage where you put a puncture through the liver, as I'll show you. This is hepaticogastrostomy. So I would rather put a guide wire across into the jejunal loop. But this patient had a radical cholecystectomy, and an entire jejunal Roux-en-Y loop was also jammed here. So we were not very sure whether this will drain further because there was obstruction lower down. So therefore, we did a hepaticogastrostomy in this case, and we left a stent into the stomach. Now, we don't routinely perform this procedure because majority of our patients where ERCP is successful, almost in 99.9% of cases, these are cases of pure palliation where patient has very advanced malignancy and you need some things. Coming to the LAMS and the hot axios, I want to share with you that why we do EUS in every patient of a pancreatic or periampullary neoplasm or a biliary neoplasm. And this is one such case I want, especially those who are having a lot of skepticism about EUS staging ability. This patient had a very proliferative tumor extending into the bile duct. And I want you to see a small 6 millimeter lymph node in the mediastinum, subcarinal region. We took EUS FNO of this 6 millimeter node with a 25 gauge needle, and it proved to be metastatic adenocarcinoma. So irrespective of the resectability possibility locally, I don't think any surgeon for me can cure this patient when you have a lymph node sitting in the mediastinum. And these are the patients where you use a one-step delivery system of hot axios and deliver the goods to this patient in terms of a short biliary decompression. So my take here is that if I have a patient with a proliferative ampullary or lower CBD tumor, I would rather go de novo, straight first EUS guided biliary drainage, no ERCP, put a metal stent, preferably hot axios like this, and because you are away from the primary tumor, so no tumor ingrowth, no tumor overgrowth situations usually happen in such situation. And this is what I feel is the future of palliative care in obstructive jaundice in proliferative lower bile duct tumors or ampullary tumors. There are a lot of studies regarding EUS-guided cholangiography and biliary drainage. The complication rates have been extremely high because of a very steep learning curve. So I would only do this procedure unless you have adequate experience in handling thousands of EUS-guided interventions, especially FNA as a background, to have a mastery in this area. There was an international consensus recommendation for difficult biliary access in ASG by ASG, and they compared which one is a better route, transgastric or transduodenal, and both has its own advantages and disadvantages. But for me, if you ask me, if a bile duct is bulging in the duodenal bulb, I will do a EUS-guided choledochondriostomy, one stop, because remember that when you go transgastric, antegrade, you are going to spend a lot of time. And when your needle site puncture is going in the liver, exchange of wire and intervention will lead to biliary peritonitis to a certain degree, which you can avoid if you do a choledochondrostomy. So my take is still EUS-guided biliary drainage through the duodenum if possible. EUS-guided pancreatic ductal interventions are far-fetched because they are technically demanding, and if I feel that a surgical option for such patients or chronic pancreatitis would be much better, especially for chronic pancreatitis and stones. I would only reserve this procedure for disconnected duct syndrome, where you need to put a stent in the tail area and leave the stent end into the stomach so that the fluid collection does not recur. There are some details, but as you can see, the complication rates are very, very high. And we all would know, all the experts across the world have faced their own challenges when you try to drain a pancreatic duct. Coming to celiac plexus neurolysis, I would suggest that though we started way back in 1999, ever since we got an FNA almost 22 years back, I'm not a great fan of this technique at all. Sorry to say that. A lot of studies have been published. They say it is effective for 3 months, 6 months, but I still feel that we have still not mastered this technique. So I would not be the right person to talk about EUS-guided celiac block or celiac plexus neurolysis. I only do this only and only if patient insists or the referring doctor insists. Coming from there to fiducial placements, those cancer centers who are doing very specific radiotherapy units, then they can possibly benefit with fiducial placement, EUS guided into the pancreatic tumor and targeted sites or even lymph nodes, and then guide the therapy. So this is an interesting area which needs a lot of study, which we don't have. EUS-guided gastrojejunostomy, yes, these are early days, and I want to tell you something, that we are still trying to do all these procedures with one platform, which is not specifically designed for this. And therefore, I feel we still don't have an ideal technique or ideal platform to do a regular EUS-guided gastrojejunostomy. You need a lot of experience because the complication rates still are high, even those who have tried it. Lumen opposing stent, I'm going to skip that, but EUS-guided vascular interventions. I know Egypt is a land of varices where you guys have probably the largest experience in the world. And I don't have to tell you, but I am still not very confident about EUS-guided treatment of varices, be it gastric varices or junctional varices. I'm still not convinced because the standard glue technique for me is still works very well. So I'm still awaiting a real breakthrough in a randomized controlled trial, multi-center, with a technique which tells me to switch over to pure EUS-guided treatment of varices. I'm not going to show in details, but there have been cases of vascular aneurysms which has been very effectively treated under EUS-guided intervention, coiling, especially the splenic artery aneurysm after a large attack of necrotizing pancreatitis and so forth. So yes, there are some anecdotal cases which has been published in the world literature, and this can be done. But again, as I said, this is still a very, very niche area for research in large cohort of patients. Coming to EUS-guided ablative techniques, we have heard Brugge talk about and others in Mayo talk about, insulinoma treatment and cystic neoplasm, alcohol ablation and paclitaxel and all those things. But I want to ask you today that if a patient is reasonably surgically fit, I still feel that these are techniques which are still questionable. So I want all of you to ask a question. Suppose this patient is your family member in 50s and the cystic lesion is resectable. Would you offer this procedure or you do something else? So RFA and all this alcohol injections and ablative techniques with chemotherapeutic agents are still under intense research. And I don't think we have arrived into that area, because I have seen in some of the live demonstration massive complications when somebody was trying to demonstrate an RFA where a massive bleed occurred and patient died on the table. So I personally feel that if I am in private practice, my outcomes are extremely important and the outcome depends on the safety of the procedure. Having said that, ladies and gentlemen, the level evidence, the level 1A evidence of published literature is still sparse in terms of EUS-guided therapeutic interventions, as we all know. Most important, my observation would be that EUS-guided pancreatic fluid collection is established. There is no discussion on this, including, I would say, well-selected WOPN. Yes, you have to consider EUS-guided drainage. EUS-guided celiac block, I personally don't do it, but there is a lot of encouraging evidence for it, which I don't know, as whether I have not learned the technique or I'm doing something not right. EUS-guided biliary drainage, I would say, yes, it is here to stay, and more so because of bariatric patients. And now more and more challenging cases we see. I think PTC, I have not asked for a PTC guy to give me a wire or a rendezvous over last 1 decade or more. So I think PTC, as far as hilar cholangiocarcinoma, I'm talking about bismuth type 4 stricture, yes, you still need PTC, but not anything below the common hepatic duct. I think it is straight away EUS-guided biliary interventions. Pancreatic duct drainage, I still feel it's still a challenge. The problem here, guys, is that we are still using a lot of ERCP accessories to do in EUS intervention, and that is our problem. So dedicated EUS scopes we need, and dedicated EUS platform, therapeutic platforms we need. I personally feel ERCP should be mastered by every endosonographer first. And there should not be any excuse because I did not succeed in ERCP, I was trying an EUS-guided biliary drainage. I don't think that explains. And if you do that, your pancreatic interventions success rate will drop. Proliferative ampullary tumors, I think it is probably one of the finest indications for metal stenting, EUS-guided transduodenal if possible. Gallbladder drainage in very select cases, bedside, if patient is extremely sick in an ICU. EUS-guided ablative treatments, very early days, vascular interventions, still anecdotal as I see. EUS-guided anastomosis with current techniques and technology, I still feel it's an experimental technique because we don't have a dedicated platform. I am not very comfortable because I cannot afford complications in my patients, because for that patient you may have 5% complication, but in that patient it is 100% complication for that particular patient. So you have to decide, youngsters, especially those who are very enterprising endosonographers, what can be done and what should be done. Let's keep it in our minds all the time. A lot of things can be done, but you have to do what should be done for the patient's safety and a predictable outcome. The only question here is the limited availability and infrastructure and well-trained endosonographer. I'm talking of a large number of endosonographers, and therefore we are having these problems with development of EUS-guided platforms. With this, I would like to thank you all for this patient time. Thank you.